Morning, good afternoon, muy buenos días, buenas tardes. My name is Baltica Cavieses, and I will be hosting this third webinar from this webinar series entitled Health of Migrants and Refugees, Catalyzing Research Evidence Exchange between Chile and New Zealand. This first series of 6 webinars aims to create a robust and rich exchange of findings and methodological practice related to the health of migrants and refugees between Chile and New Zealand. Chile and New Zealand, despite being on opposite sides of the Pacific Ocean, share several interesting similarities in terms of geography, agriculture, and natural resources, marine and environmental focus, and relatively small populations with long-lasting stable democracies coming from decades of progressive policies. This webinar series is co-organized by the Center of Global Intercultural Health at Universidad del Desarrollo in Chile, which is also a WHO PAHO collaborating center on capacity building for training and research on the health of migrants and refugees, and the Center for Migrant and Refugee Health Research at the Auckland University of Technology in New Zealand. This webinar series is also supported by multiple organizations and institutions: Lancet Migration Latin American Hub, Chilean Network of Research on Health and Migration, RECHISAM, New Zealand Policy Research Institute. In this third webinar, we will be discussing the mental health and well-being among migrant and refugee communities in New Zealand and Chile. Understanding mental health and well-being among migrant and refugee communities in these two countries is essential for advancing health equity and informing culturally responsive policies. This population often face unique stresses, including forced displacement, acculturation challenges, discrimination, and limited access to services that can significantly impact their psychological well-being. In both countries, where migration patterns are shaped by distinct socio-political contexts, research on mental health provides critical insights into the structural and social determinants affecting these groups. Such knowledge is vital for designing inclusive health systems that address the specific needs of migrants and refugees, reduce disparities, and promote social cohesion. This webinar 3 is entitled Mental Health and Well-being among Migrant and Refugee Communities in New Zealand and Chile, Evidence-Based Lessons and Challenges. To begin with this session, we will welcome presenter Teresita Rocha. Dr. Teresita Rocha Jimenez is a public health researcher specializing in migration, mobility, and health equity in Latin America. She holds a PhD in public health from the joint program at the University of California, San Diego, and San Diego State University, and currently serves as associate professor at Universidad Mayor in Chile. Her work integrates qualitative mixed methods and geospatial approaches to examine the health of migrant and mobile populations, particularly in border regions. Dr. Rocha Jimenez is co-investigator on a Fondesit project, contributing to a growing body of evidence on structural determinants of health in vulnerable communities. Dear Teresita, it's wonderful having you today. Thank you so much for being with us in this third webinar. I remind you have 12 minutes to present, and the screen is now all yours. Thank you.
Thank you so much for the presentation and for the invitation. Good afternoon, everyone. I will be presenting today findings from our study entitled My Family is Always Backing Me Up: Social Support as a Protective Factor of Risk of Depression Among Haitians in Chile and in Mexico. This research was conducted by myself and by a student from the Columbia University, from the Maimel School of Public Health of Columbia. So probably, as some of you know, Migration is often seen as an opportunity because it can lead to better safety of those who migrate. It can improve access to education, improved employment, safer environments. But migration and mobility and displacement can also expose individuals to multiple stressors, such as discrimination, precarious living conditions, and limited access to services due to migration status. According to the World Health Organization, migrants experience higher rates of mental health disorders in comparison to the general local population, particularly post-traumatic symptoms of depression, anxiety, and other psychiatric disorders, with some studies showing depressive prevalence as high as 40% among migrants. However, there are other elements that may protect symptoms of depression among migrants and displaced populations, such as social support. Social support plays a crucial role in buffering these stressors. It has been shown that social support protects against both physical and mental health deterioration among migrant populations. Interestingly, studies indicate that the protective effect of social support is strongest among recent migrants as it helps them navigate uncertainty and rebuild networks in their new destination. Some of the pictures that I'm going to be showing to you were taken both in Chile, like the one in the left in a migrant settlement, and the right one was taken in Tijuana, Mexico, in the border between the US and Mexico, where this study took place. So the Haitian migration in the Americas has intensified due to multiple crises. The 2010 earthquake, an ongoing political instability, and a cholera outbreak that happened around the same time. Many Haitians migrated first to Brazil or Chile and later to Mexico en route to the United States. Policies in Chile became stricter in 2018, pushing many migrants into an irregular status and forcing secondary migration northward. A lot of migrants from Haiti traveled to Tijuana, to the border, during pandemic, traveling through irregular points of entry in very precarious conditions to try to enter to the United States. So the goal of this study was to understand how social support functioned among Haitian migrants in Chile and in Mexico once they arrived there, and whether social support was a protective factor of symptoms of depression. So for this study, we conducted a sequential explanatory mixed method study, which means that we first conducted a survey in both countries, and then we conducted in-depth interviews and ethnographic observation to try to inform what we were finding in the quantitative component. We administered surveys including sociodemographic questions, the Center for Epidemiological Depression scale, which includes 20 items, and this was conducted in Spanish and in Creole. We also used a social support survey to explore how they felt, how strong their social support networks were in both countries. We also conducted in-depth interviews, and something interesting about this study is that we were able to interview people in Chile. We were able to capture their transit experiences to the Mexico-US border. Then we did interviews in Tijuana, and we were able to interview people again who were deported from the US to Haiti and they went back to Chile. So we had kind of pictures of the different migration journey of this population. So we collected data from February 2021 to March 2022. And in Chile, we conducted mainly in a migrant camp. You have seen pictures of that place in a neighborhood called Cerrillos, where a lot of Haitians lived and moved there during pandemic. We would go every Sunday to conduct between 10 surveys and in-depth interviews. And because we were present for a very long time, we built strong relationships with the community. In average, people have been in Chile between 5 to 6 years. In Tijuana, the data collection was a little bit different. We were only there for 3 months. We were present during an important COVID-19 outbreak, and the Title 42 was in place. This meant, this entailed that all of migrants who were trying to go to the US had to wait in Mexico for the refugee asylum request to be solved. So there were a lot of migrant camps at the border. People were living at the streets in very vulnerable conditions, and there were tensions between migrant groups. Some people have been waiting a year to hear from their visa, humanitarian visa status, and Haitians just arrived there. So the conditions in which we collected data was very different, and this may explain also the differences in the results that we found. So we conducted some analysis. For the quantitative part, we analyzed the scale, and people who had 16, a summatory of 16 in the symptoms of depression were considered that had a risk for depression, clinical depression. We conducted a varied preparatory and analysis between symptoms of depression and social support. And then we also included, we controlled for covariates like country of interview, time in the country, if they felt that they were migrants, Spanish proficiency and level of education, and if they went to a doctor constantly. So I don't want to stop a lot in the numbers, but some of these, I would like to highlight some of the findings. In Chile, 30%, almost 31% of the participants presented symptoms of depression. In Mexico, this was considerably higher. It was almost 90%, reflecting the recent arrival, uncertainty, and stable living conditions of migrants at the border. Of course, the time spent in each country may also explain this prevalence. We identified that identifying with a religion, because this was something very important that we asked, reduced the odds of depression by 9%. Having someone to take care of them when sick reduced it by 63%, and having someone they could trust reduced the odds of having depression symptoms by 73%. These findings highlight the central role of social ties and trust in mitigating mental health risks among this population. However, there are some differences between the migrants interviewed in Tijuana and the ones interviewed in Chile, as the recent arrival may explain the lower networks and social support among those in Mexico. I also wanted to share some qualitative insights that may complement the quantitative findings. So interviews give life to these numbers, and participants describe arriving to Chile feeling welcome, sometimes by friends and family. Most of them had a family member or a friend already in Chile when they migrated here. And as you know, the language is different, the culture is different. So having someone at the place of destination was very important. Another person said that after deportation, his family sent money so he could come back to Santiago. Haitians are always supporting each other, and after 3 months, I was back. There was nothing that I could do over there, and I might try to cross again to the US, as I have some cousins in California. So some of the people that we interviewed and were deported were trying to go back, going throughout this very precarious and difficult journey, because they wanted to go back to the US. And as I mentioned before, this was during the pandemic, so things have changed a little bit. And just to close, some key takeaways of these findings is that social support through religion, caregiving, and trust acts as a strong protective factor against depression symptoms. However, prevalence of depression was higher among migrants in Mexico, likely because they were new arrivals and still coping with recent traumas. This population has gone through a myriad of traumatic events, so we need to be cautious about the depression symptoms that we're presenting right now. And I wanted to thank the participants and the organizations and the project that made this project possible. Thank you so much.
You, dear Teresita, for this really interesting presentation that combined quantitative and qualitative methods, allowing for a deeper, more holistic view or vision around the mental health of migrants in both Chile and Mexico. Really interesting comparison as well, given that they are countries that are not bordering between each other and that they represent people migrating to different directions and places in the region. So that's really interesting. Thank you so much for that.
Thank you.
We will move on now to our second group of presenters from New Zealand. I will introduce Dr. Yaga Maya Shrestha Ranjit, Dr. Shabnam Jalili Mogadam, and Dr. Tula Branali. Dr. Jayamaya Shrestha Ranjit is a senior lecturer in nursing at Auckland University of Technology, New Zealand, with over a decade of academic and clinical experience across Nepal, Australia, and New Zealand. She holds a PhD and a master's degree in nursing from the University of Melbourne, a graduate diploma in tertiary teaching from AOT, and a bachelor degree in nursing and midwifery from the Tribhuvan University, Nepal. Her research focuses on community-led participatory approaches to health promotion among ethnic minority and migrant populations, with particular attention to social justice, health equity, women's and child's health, and pain management. Dr. Thresta Ranjit is affiliated to the AOUT Migrant and Refugee Health Research Center and has led several strengths-based projects with sustainable community outcomes. For her part, Dr. Shabnam Jalili Mogadam is a New Zealand registered nutritionist and a research fellow at the AUT National Institute for Stroke and Applied Neurosciences. Her academic training and professional experience span Iran, Malaysia, and New Zealand, giving her a broad perspective on nutrition within culturally diverse healthcare contexts. Her work focuses on advancing community nutrition, health promotion, and chronic disease prevention, with a particular emphasis on food patterns, eating behaviors, and ethnic differences. Shabnam has extensive experience in national and international research projects and in collaborating with diverse multi-ethnic teams. And finally, Dr. Tula Branali is Associate Professor of Mental Health, Nursing and Head of Research at the School of Clinical Sciences, Auckland University of Technology, AUT, New Zealand. She holds a PhD in social policy from the University of Birmingham, where her research focused on care ethics and citizenship in dementia care. With a background in mental health nursing, her academic trajectory spans institutions in the UK and New Zealand, including Massey University and the University of Southampton. Dr. Brunelli's research critically engaged with the ethics of care, social justice, and the lived experiences of marginalized populations, particularly older adults with mental health conditions. She's a founding member of the Care Ethics Global Network and an active contributor to international collaborations on care and citizenship. Thank you so much, the three of you, for being here with us today. As you know, there are roughly 12 minutes for your presentation. We really look forward to hearing your experience and knowledge on the topic. And now the screen is all yours.
Kia ora koutou, I'm going to go first here. So this is Chula Branali to talk about mental health and wellbeing in Aotearoa. Thanks for the invite to start off with. Thanks to Teresita for that fabulous presentation, because I think you've highlighted many of the universal issues affecting migration and the experience of migrants. So we can build on that and not repeat it. And thanks to Shabnam, who's moving the slides. So really what I wanted to do is to focus on, there's a couple of papers that we've included in the slides here. And what I want to do today is really pick up on a couple of points that I've been reflecting on since the publication of a paper around mental health and wellbeing in Aotearoa for refugees in 2024. And that was done a group of us through the Migrant and Refugee Health Research Centre got together to do that paper. And I think the focus on culture is very, very important and very, very interesting, particularly from a care ethics lens. And everything I tend to do comes from a ethics lens. But what I've been really thinking about is the role of culture in well-being and how culture impacts constructions of health and well-being in new countries, in resettlement conversations, and even in the language that we use to talk about well-being and migration. So I'm just going to talk a little bit about the bicultural context here in New Zealand because that does offer us some opportunities. The Te Tiriti allows by Māori for Māori approaches to mental health services, which are usual culturally based services called kaupapa Māori services. And they are to avoid iatrogenesis or harmful impacts when seeking help for distress. And Māori have been very much negatively impacted by colonisation and by psychiatry. And so that gives us a pathway forward, we think, to think about other marginalised groups. And our inquiries and our policy have definitely highlighted the need for new ways of thinking about mental health and reaching more marginalised populations. So in our next slide, we're just going to draw on another piece of work. Thank you, Shabnam. So the refugee experience is the same here as it is elsewhere. Access to the help needed when facing distress continues to be out of reach for marginalised populations or communities. So we know that the same sort of issues that are happening elsewhere also happen here. The next slide tells us that one of the issues here is that often the responsibility for service access is misplaced onto communities rather than the responsibility of services. So we talk about refugees not being able to communicate or to be able to describe symptoms in a way which is understood. All of those kind of responsibilities are placed on a burden of presentation of health in a completely different context and out of culture. So the thing that I want to pick up on is that we sort of thought about this in relation to our paper and put forward a bit of a different position, but I think I've thought about that on again since then. And the thing that I want to pick up on just in this final bit is that the responsibility for service access certainly needs to be replaced back with community or with services rather than with communities. That the structures set by psychiatry are powerful organising structures that govern access, assessment and treatment. Psychiatry as a science has rejected ideas of cultural understanding of faith as part of mental health. And this is its own culture. So we've got this culture clash really going on. Refugee becomes the dominant identity rather than how the person integrates and understands their trauma through their own cultural lens. And trauma is then again pathologized into illness language. And that prompts treatment responses that are also kind of clinically based and not thought about. So as Teresita was talking about, my final slide here says that the lens through which community organisations already view well-being are able to mitigate distress by supporting well-being. Trust is so important for recovery, and that is where people can engage and express themselves and their distress in the ways that can be heard. Thank you.
Kia ora, greetings. Thanks for the opportunity for this presentation. I'm Jagmaya. Today I would like to share with you briefly about a project, part of the project in relations to mental health services for Bhutanese refugee women resettled in New Zealand here. Bhutanese people are Bhutanese citizen of Nepali origin, and therefore I share some common socio-cultural heritage with them that help me to build relationship and conduct this study in the language they prefer, that's Nepali. So aim of this study was to examine the effectiveness of primary healthcare services for this community, and was a qualitative study and conducted here in New Zealand in 2 big cities where they are mostly resettled. And so we tried to collect the information from Bhutanese refugee men and women, and also from service providers in this study. And so I'm going to briefly outline the key findings here from the perspective of Bhutanese men and women. And they highlighted that they have been experiencing high level of mental health issues such as anxiety, stress, depression, and some of them were already having medication for that, but many of them thought their symptoms were hidden. And they thought these conditions were contributed by their refugee trauma, their resettlement stress, language barrier, social isolation were identified being a very significant issues, and then cultural dislocations. Some of their these statements, I just put it here for your reference as an example, what they had to say. And so they identified number of barriers, which also highlighted the, related to their language barriers and stigma and lack of awareness of the services. So in terms of, thank you, Sabnam, for moving the slides. So in terms of the findings from, previous one, please. The findings from the health professionals were that they acknowledged that this population group's mental health issues were very complex due to their socio-cultural complexity, and they identified the need of culturally responsive care. They identified gaps in training and resources for themselves, and some of them thought they were underprepared to provide effective culturally safe services to this population group. And so, and then they thought both group that the community project, community support, particularly the Bhutanese men and women, thought would be very helpful, as previous presenter has already highlighted. However, they thought this could sometime be reinforcing the stigma related to mental health within their community, and also may prevent from accessing professional health services due to their cultural stigma related to mental health. So considering the findings from both perspective, it is recommended that to have an improved cultural, sorry, Sabnam, you share something? Good, thank you. Improve cultural competence health professionals to give them more information training and have more engaged mental health literacy for these community people, and increase access to more interpreters. That was significant issues, and affordable health services for them. And so to conclude, primary healthcare services can be vital in addressing health needs of mental health needs of this population group. However, it requires greater cultural sensitivity, better accessibility, stronger community health system in partnership with the community people, which brings the community-based participatory research approach with them. So this is the basic findings of the bigger study, and I have included the literature, the article that published. I have 2 other articles related to this project as well, and happy to share that later. Thank you so much again for the opportunity.
Thank you very much, Jagamaya, and sorry for that technical issue. I clicked on the wrong button. So the first study that I'm going to share with you is about titled Exploring Factors Affecting the Well-Being of Recent Migrants and Former Refugee Resettled in Aotearoa, New Zealand. This study is a collaboration between researchers at AUT Migrant and Refugee Health Research Center, as well as Belong Aotearoa, to explore the perspective of migrant and refugee background communities in Aotearoa, New Zealand, regarding well-being and factors that influence their well-being. So this is a feasibility study to evaluate potential for larger scale research in the future. And we are following a mixed method approach with an anonymous survey followed by a focus group discussion. Anyone coming from the migrant and refugee background older than 18 years old, they are welcome to join us. At this stage, we are finalizing the translation of our survey, and we are hoping to launch our survey by end of this year or early of the next year, followed by the focus group conversations. So the expected outcomes, the key outcome that we are hoping is to generate insights that can help inform policy to improve resettlement experiences for New Zealand migrants and refugees. So please watch this space when the results of this study is going to be shared with a wider people across our academics as well as the community. So the second study that I'd like to share with you, titled The Impacts of Northcote Urban Regeneration on Community Wellbeing. So let me provide a little bit background here. Northcote is located north shore of Auckland with the most deprived quintile, highest state social housing intensification. And the Northcote Development Program, which was started since 2016 with the aim of improving physical and economic conditions. But one of the some of the things that has been raised about that program was the population growth as well as some of the risks. Therefore, Health and Minds and Health and Wellbeing Agency located at North Shore, with their community collaborators, they commissioned this study with the aim to identify the impact of Northcote Development Program on the well-being of Northcote Central community, which includes migrants as well. So in that co-design study, we used a survey as well as a focus groups on the mixed method model. And unfortunately, we were not able to continue the data collection longer than 2 months, which was conflicting time with the COVID time. And half of our participants who completed the survey, they were coming from the migrant backgrounds. So here I have provided a summary of the information related to the food, activity, and socialization opportunities. If you're interested about further of the outputs, you can go through the report, which is open access. The need for more and different kinds of spaces for community was raised, and half of the participants wanted more outdoor and green community spaces. Some of the Kainga Ora participants coming from the social housing, they shared their regrets about the demolition of the previous social housing stock, and they were asking for the space for hangi or kava. For those of you who don't know what is hangi or kava, hangi is a Maori cooking style, which is under the ground, and the kava, it's a non-alcoholic allowed drink in New Zealand. So through this survey, when we were asking people about their well-being and what are the factors that can impact or improve their well-being, it was very interesting to see that 75% of the people, they mentioned about the importance of healthy eating, 52% about the importance of physical activity, and 37% of the people highlighted the importance of social network. So at the end in this report, it was highlighted that there is a need for better engagement and communication, multilingual support for diverse communities, increased funding for social services, and infrastructure to sustain cohesion as population doubles in that area. So I really like to acknowledge the invitation and your attention. Thank you.
Thanks so much to the three of you for this wonderful integrated presentation. I really liked the vision of complexity in multi-ethnic, multicultural settings and learning from the New Zealand experience. Also connecting that with primary care and the idea of misplaced responsibility, as well as the element of co-building visions and insights to promote policy with grassroots data collection from communities themselves. Wonderful insights. Thank you so much. We will now move on to the second section of our webinar, in which we will have some experts commenting on the presentations and also sharing their own experiences. For this, I will first invite Blessing Kanengoni. She's a public health researcher affiliated with the Migrant and Refugee Health Research Centre at the Auckland University of Technology, New Zealand. She holds a doctoral degree and has developed a research trajectory focused on health equity, with a particular emphasis on access to healthcare for migrant and refugee populations in Aotearoa. Her work employs integrative and qualitative methodologies to examine structural and attitudinal barriers to healthcare, and she has co-authored peer-reviewed publications that inform policy and practice in culturally responsive health systems. So I welcome Blessing. Let me invite you to start your video and start your audio as well, so that we can have you here. There you are. Thank you, Blessing, for being with us today. It's wonderful to have you. You have 5 minutes for a free comment around this presentation and this topic generally. Thank you, and the screen is yours.
Thank you so much, Valtika, for this space. And I also want to acknowledge the presenters for the remarkable work that you've been doing in this space. So I was just noting down differences and similarities and presentations from New Zealand and also from Chile. Even though that I have noticed that the population focus in terms of the ethnicities might be different, and the context as well. Like, for instance, we see that with Chile, we're looking at migrants who, like migration stress during transition and resettlement, whereas in the context of New Zealand, we're pretty much looking at resettlement challenges in the context of the New Zealand health system. What I do also notice that with the key protective factors, with Chile, we are looking at the migrants look into religion, trust, care during illness as the protective factors against mental health. And then when we are looking at, in the context of New Zealand, the refugees and migrants are looking at cultural competency and community-based services that actually enhance their mental and health well-being. I also note that one of the key findings that Chile highlighted was that social support reduces depression, and depression odds significantly. This is pretty much the same context with New Zealand, even though New Zealand we're looking at more for the need of culturally responsive care. And then when we're looking at the similarities, what I want to acknowledge is that the role of social support is quite cuts across all presentations. For instance, both presentations highlight social support networks and the need of community green space as critical for mental health well-being. Community engagement is also seen as a protective factor against mental health deterioration. I also noted that barriers to accessing health is an issue in both contexts. For instance, when we're looking at barriers in languages, considering that migrants and refugees come from countries where the common language in the hosting countries is not common to them. And again, the lack of cultural competent care appear in both. And what the key takeaways that I note as well is that, and this is quite universal as well, is that social support is universal, is a universal protective factor, but its form and impact will vary in context. Again, I highlighted the need of cultural responsive and systematic adaptation to be quite critical in promoting mental health amongst migrants and refugees. Like for instance, in New Zealand, this is quite critical, whereas in Chile, I note that basic survival and trust networks dominate migrants in transition contexts. Both presentations talk about community-based approaches, but then when we're looking at New Zealand, it's more of emphasis on policy reforms and rights-based frameworks. Earlier on, we heard Associate Professor Tula talking about Te Treaty and the articles that govern the work that we should be doing. And then, whereas with the context of Chile and Mexico focuses on individual coping and informal networks to survive. What I believe will be the future direction is to integrate cultural competence with strong community engagement and policy advocacy to address structural and systematic barriers. Thank you. Over to you, Baltika.
Thank you, Blessing, for that panoramic vision in which you depicted some key elements of each presentation and connect them across with commonalities and distinctions, which helps us think of on a cross-Pacific vision of multiculturalism, intercultural health, mental health and well-being, and primary care generally, and its connection with policy development. So that was incredibly useful and bright. Thank you so much. We will now move on to our second panelist, producing the comments, and he's Jean-François Aguilera. Dr. Jean-François Aguilera serves as a regional health specialist for the Americas, based at the IOM Regional Office for the Americas and Caribbean in Panama. His background is medical epidemiology, with various experiences of project development and implementation for different organizations and donors, such as NGOs, UN agencies, European Commission, private sector, mainly in Africa, but also in Latin America and Europe. Dear Jean-François, you are a permanent commentator in this webinar series. It's wonderful seeing you again. And please kick off with your vision on this huge, incredibly important topic and the beautiful presentations we just heard about. Thank you.
Thank you, Baltika. Muchas gracias. Good evening, colleagues. So, yeah, very interesting session. Yeah, and I became, very used to the sessions with Baltika and other colleagues. So it's always a pleasure. Greeting from Panama, where I'm based. So I concur with other presenters on the importance of mental health and psychosocial support for migrants. And we have the same experience and at IOM on the needs, and MHPSS is embedded in IOM strategic plan 2024-2028. So it's really a core function of our interventions. Most of emergency interventions we do include MHPSS component, and we have specialists in this area. And recently, IOM developed a manual on community-based MHPSS in emergencies and displacement, which is, I think, is a global reference for designing and implementing MHPSS program. And I will happily share it with Baltika, so if colleagues are interested. And yeah, as I said, we intervene across the world, and in particular, my area of duty is more Latin America, but around the world we develop MHPSS program. To give you an idea, in 2024, in 83 countries where we intervene, we have reached up to 1.8 million migrants with MHPSS services, and we have trained over 25,000 professionals. Our goal is to support people, help them. We observe the same symptoms and syndromes as the ones that were presented, and our goal overall is to follow community-based, culturally grounded approaches to strengthen resilience and social cohesion among migrants, but we also target vulnerable host communities which are also affected by migration. So that would be my my input, and over to you, Baltika. Over.
Thank you so much, Jean-François. It's really interesting to hear about the IOM's experience, which is vast in this topic from different countries and regions. And it can also inform on development of implementing guidelines and recommendations and visions, concrete visions for improvement of mental health and well-being of migrant and refugees communities globally, which also has commonalities in terms of migration, regulatory processes, acculturation challenges, discrimination and marginalization, structural barriers, language difficulties, just to mention a few, which can be context specific, but also are shared globally, which is really interesting given IOM's broad experience. Thank you so much for that. And if you would like to share the information you just said, it would be greatly valued, and we could share it with our database of people registered to the webinar. That would be wonderful. Thank you. We will now move on to the third person commenting in this session. She's Alejandra Carreño Calderón. She's an anthropologist from Universidad de Chile with a master's in ethnopsychiatry from University of Geneva, Genova, and a PhD in cultural anthropology for University of Siena. She's an associate researcher at the Center of Global Intercultural Health at Universidad del Desarrollo in Chile. Her work for many years is centered in health anthropology with emphasis on migration, mental health, indigenous communities, gender, and the health and well-being of children and youth. She has led and participated in multiple academic networks, such as the Chilean Network of Anthropology in Health and the Chilean Network on Research on Migration and Health. And she has a vast scientific production on the social determinants of health, interculturality, and health in communities and populations in mobility. Dear Alejandra, it's so wonderful to have you with us today. Thank you for your time. Please, the screen is all yours for now.
Thank you, Baltika, and thank you for all the colleagues who share their works in this incredible webinar that led us to share the point of view from a very long distance countries. Even though the mental health of migrants and refugees people may be affected by conditions in which migration takes place, these presentations show the importance of identifying the existence of protective factors and elements such as solidarity, sociality, and reciprocity as a network that supports highly precarious flows. And I think that these elements emerge from all of the presentations. Teresita presentations shows that the road that taken by the Haitian diaspora in Latin America and the role that played by factors such as religion and the existence of others who care or others who care of you, even from a distance, in order to sustain mobility, without which the continuity of life of this kind of communities will not be possible. Research with children and adolescents migrating through unauthorized border points, cross points in South America that uses participative methods has also revealed aspects of mutual care, solidarity in the reproduction of this kind of type of migrations. So we have shared a different results, findings that have many things in common, and that talks about these protective factors and this social organization of care. The presentation of colleagues from New Zealand shows some similar topics with Chile, as for example, the sense of otherness that's found among migrant people in the healthcare system, the difficulty to navigate new health system that is very fragmented as the Chilean one. In Chile, we have a mixed private and public system with enormous inequalities among them. High direct costs, unavailability of interpreters and cultural components and service providers, all these factors are very common also in Chile. But unlike in Chile, the presentations show a deep awareness about the post-colonial context in which they work, where migration is just the most recent part of a history of colonization that has shaped the social order that configures the present. And this is very interesting to note, the awareness among healthcare teams themselves of the limitations of Western psychiatry in interpreting the suffering of culturally diverse people, the need for cultural responsive care. Finally, and in addition to highlight the structural, historical, and political aspects that emerge from the mental health care needs of these people, I would like to emphasize the value of community-based interventions that appears in the presentations of all the colleagues, the existence of religious aspects in understanding suffering and reversing it, and the role that traditional healers in cultural appropriate interventions for people who are in need. Thank you.
Thank you, Alejandra, for this vision from medical and health anthropology in connecting some dots that are underlying all presentations, and the idea of colonial, structural, historical elements that we can see today and mirror our history, but also our way of seeing each other, the sense of otherness, and how that builds up in interactions that provide an equal power and unfair relationships and structures. Thank you so much. It was incredibly interesting to hear. And I think it illuminates a lot about underlying processes and mechanisms that are within problems, challenges, and difficulties that we see today. We're now heading to the final part of our webinar. It has been running so quickly. And for the last few minutes, I will invite all panelists to turn on your videos. And I will ask one general question. And I will ask you to, whoever wants to respond first, just raise your physical or digital hand so that I can give you 1 minute's time to respond to it. And the general question is very simple and straightforward, yet not necessarily easy to respond, given context and reality. There is plenty of evidence, both in Chile and New Zealand and other countries and regions, of how mental health can be deteriorated among migrant and refugees populations. However, despite that evidence, not every country has developed policy or practice concrete solutions to that for these unique populations. What would be, in your own words, your 1 or 2 action points that need to be produced, created, developed, to connect the dots, the gaps between research and policy making in your own countries? 1 or 2 action points that are still needed to be developed to connect the gap between research and practice in mental health of migrant communities and refugees in both countries. So who would like to go first with a minute response? Blessing, please go ahead. Thank you.
Okay, yeah, like what you said, Baltika, it's not a easy question, but then just from the top of my head, I'm just thinking that most of the times as researchers, we identify a gap within literature or within research and not consider the government priorities or initiatives. So I think that what we need to be doing as researchers is to engage the government more, try and then align our research in ways that inform how we go forward, because we can come up with all these findings, come up with recommendations to policies, but if they do not speak into the government initiatives or their 3-year plan, at the end of the day, what we're trying to address, because might not actually work in our favor. It'll be just research, 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 and not going forward. That's my 2 cents on it.
That's wonderful, Blessing. Thank you so much. Very straightforward. Jean-François, please go ahead.
Yes, thank you, Baltika. Yeah, IOM is not a research institution. We do some very practical and on the ground, to the ground research, but my main point would be that a lot is known already about what is needed, what can be done. Of course, research is always welcome and it's normal, but a lot is known and not applied on the ground for various reasons, finance or lack of knowledge, but already to push for implementing what we know and what is much needed, as was mentioned by various presenters today. So, but of course, research always welcome, and we need to go further, but a lot is known already on this topic. Over.
Thank you very much, Jean-François. Very, very true. Put the energy and the emphasis on implementing. Teresita, please go ahead.
Yeah, I just wanted to highlight some of the things that the colleagues said, but I would go to the other side of what Blessing was saying, to involve the community in these implementations. Because, for example, Haitians have a very particular and different perception of what is a good mental health or depression, that it's probably very different to what we measured, and we are aware of that, right? So we had people from the community designing the instruments, implementing and analyzing. So I think we should do the same in a public policy and recommendations, because otherwise it's just researchers and government, but then there's this breach of the actual population who needs these services.
Thank you, Teresita. Wonderful connecting with communities from the start and making them a key partner and a friend, a key actor on what we do. Shabnam, please go ahead.
Thank you. I also like to echo what Blessing and Teresita mentioned about the role of the community, and make it a little bit broader in saying that it's really important to include the community stakeholders and the community service providers with the academic as well. Because one of the things that I have heard from some of the people who are working with the government, they really acknowledge the work of the research, regardless of academic level or the community or both of them as a research. But most of the time they say that they are aware of those data, but what it is missing to hear for them is then so what. So this so what, which needs to be translated in a language which can be meaningful for the policymakers to put it in the actions. And as Blessing said, that based on the priorities that the government may have. So we as researchers with the community, we can think of that, okay, what can be suitable actions in a meaningful way that the policymakers can put it into the action, rather than just coming with some general recommendations that sometimes it is not easy for the policymakers to implement it to a suitable action. So that's what I think. Thank you very much.
Thank you so much, Shabnam. Excellent. Dear Tula, please go ahead.
Thank you. I think I'm just going to echo lots of what's been said, but policymakers tend to think of relational care as soft work and well-being as something that sort of sits outside the harder work of mental health and illness, but actually they're so completely interconnected. And if people have better well-being, they won't experience their symptoms of distress in the same sort of way. And so strengthening those arguments for me are really important. And I think drawing out the culture of psychiatry and of mental health services, and it being understood for what it is that it is a particular normed way of thinking about the world. And we've all kind of bought into it for some reason. It has massive power. And I think we want to just unpack that a little bit and explain make that argument to policymakers about this isn't the only way to understand how to support people. So that clinical component and where that sits and where it's useful, I think needs to be downplayed in order to support NGOs and community organisations to do the work that they're already doing. But to kind of rephrase that or reframe it, I guess, in how it supports mental health and well-being for our migrant and refugee communities. Thank you.
How interesting the vision of trying to unpack cultures within communities and their particular systems of beliefs, including biomedical ones and psychiatrists and mental health ones that are embedded in health systems that have a particular way of seeing the world and understanding health and disease processes and connecting that in a meaningful way to other systems, cultural systems such as communities, refugees, researchers, and so on. Super important. Thank you so much.
Thank you.
Yagamaya, please, your turn. Thank you for waiting.
Sure, no problem. Thank you so much. And I think I support most of the points that have already been mentioned. What I believe is that to focus on a strength-based approach rather than deficit approach. We often perceive that refugee and migrant are all weaker, they have disease and all of those things. But actually, when we acknowledge their experience and their journey, their resiliency, some of them are even better than many of us in terms of coping mechanism, resolving problem, all of those things. So acknowledging their expertise and experience, I think, is vital. The other thing is one size fit all approach doesn't work. As we already mentioned, people have diverse background and therefore need to shift our mind from working for them to working with them, the community people, exploring resources, and then having something we have, like in New Zealand, we have excellent program already put in place. We just need to do some modification and apply to the context of the migrant and refugee people. Again, having them on board from the very beginning, what we call is genuine partnership, genuine community co-design, lots of statements here, partnership, community co-design. Are we actually involving them in the policy making level to make the decision rather than just working on behalf of them? So I think those things will be helpful. I think moving forward for the win-win situation for both prospective service providers, policymakers, as well as the community migrant people. Thank you very much. Sorry, I said more than 2 points.
That's fabulous. Thank you, Yagamaya. All inputs have been relevant, useful, aware, and grounded, down to earth, to reality. So I thank you all for that. I think all of the ideas were incredibly important and useful for those who might or are actually trying to make the world a better place, a more caring, loving, ethical place, and with more sense of social justice, which is underlying the entire webinar series and this webinar session as well, of course. We are at the end of our session. It went by so quickly. Thank you, all of you, for your participation, your inputs, your vision, your experience and knowledge. It's highly valued by all of us. And I hope that this webinar is actually seen by many afterwards, once it's there out in the YouTube world forever and everyone to see. I just want to remind you, just to finish, that this webinar series includes 6 webinars, and this is the end of the 3rd one. The next 3 webinars are coming next year in 2026, and we will keep you all posted. Thank you very much again. It's a pleasure sharing this space with you, and have a great day and a great week.